Hi, this is Elliot Fishman, and welcome to part 2 of our Mimickers of pancreatic cancer. We left off last time mentioning groove pancreatitis, which is a rare form of chronic pancreatitis affecting that groove between the pancreatic head, duodenum, and common duct. One of the challenges, what happens is you see dilated common duct and pancreatic duct with narrowing. You may see little or no inflammation. You can see what looks like a mass, and so it's somewhat challenging. With groove pancreatitis, here's just a good example: dilated common duct, pancreatic duct. You're thinking about a double duct sign. There's increased soft tissue density, but then there's that low density between the duodenum and the pancreas, and that's that groove pancreatitis. That's that fluid inflammation. We've seen patients be operated on because of groove pancreatitis, so it's a very important diagnosis and something important to think about. Now, in terms of tumors, primary pancreatic lymphoma is quite rare. Usually it's B cell. We talk about lymphoma involving the pancreas when you have extensive adenopathy in the peripancreatic region or paraortic zone, but you also can see a focal infiltrating mass. Usually it's in the pancreatic head. You typically don't see common duct or pancreatic duct dilatation. It can be infiltrating, it can be solitary, or it can be multiple, and you can have nodes in the peripancreatic region. Here's a nice example of a B cell literally infiltrating the pancreas. You know this is not adenocarcinoma, it's low density, it's smooth, but you don't see common duct dilatation or pancreatic duct dilatation. You see the vessels aren't obstructed, but the vessels are encased. Just a really nice example of B cell lymphoma. Now, on CT, pancreatic lymphoma typically appears as a large, well-defined, and relatively homogeneous mass. And again, pancreatic head is most common. They're typically large, but don't necessarily need to be. And again, key things that help you with the diagnosis: main pancreatic duct is not going to be dilated. The common duct is not going to be dilated. Here's an example which really does, in some sense, look like an adenocarcinoma, but you don't see common duct dilatation. There was no pancreatic duct dilatation. Still, we thought this was an adenocarcinoma, at least on initial interpretation, and you understand why, but at the end of the day, it was biopsied and was lymphoma. And here's just another set of images. It does compress some of the vessels, but there are no collaterals seen. Another example, there are cysts in the liver, but look at that mass in the body of the pancreas. Again, you could think about mets to the pancreas. Adenocarcinoma, you should have duct dilatation. Lymphoma is something to think about. There's also a lesion in the patient's right kidney. There's also nodes in the portal caval space. Just a really nice example of B-cell lymphoma with some extra pancreatic involvement as well. We talk about unusual pancreatic cancers. Acinar cell carcinomas are rare. They're typically large. They're very cystic. Here was a good example of we thought probably was a PDAC because it was really cystic and necrotic. It could be a classic adenocarcinoma, but this was biopsied, and this ended up being an acinar cell. So just to be clear, there are certain pancreatic tumors that are in the category, if we think about adenocarcinoma, that are not necessarily on path adenocarcinomas, but again, it really does look like adenocarcinoma, but this was an acinar cell tumor, really nicely shown as well on the cinematic rendering. So if you have a large mass, solid and cystic, think about adenocarcinoma. You could think about, obviously, you're not thinking about a serous cystadenoma or a mucinous tumor unless it was a mucinous tumor that then had tumor invasion and had adenocarcinoma. But again, think about an acinar cell tumor. And again, a really nice example. Another case, same one, that acinar, right? Big mass, cystic, solid, some duct dilatation is seen. We wrote an article about this. Philippe Soyer in Paris wrote an article about this, that acinar cells have several features: large size, lack of biliary or pancreatic ductal dilatation. They're often exophytic, and have an enhancing capsule. But again, we rarely see Acinar. The case I showed you is infrequent, right? We see a couple cases a year, but it's something good to think about. Acinars will be treated very similar to adenocarcinoma, but chemotherapy may be variable. And again, in this article we wrote, and this has been a while back, I would have to say, we talked about the differential of PDAC, neuroendocrine, lymphoma, and other cystic pancreatic lesions. So Acinars are indeed a challenge, but something well worth speaking and thinking about. You can also have SPEN tumors. Now, we talk about SPEN, usually females under age 30. We've seen them in males over age 80. SPENs are often calcified or have some calcification. It's rare for PDAC to have calcification. Here's a lesion in the tail of the pancreas. Again, the patient was a bit younger, but the key thing is the punctate calcifications. You could think about adenocarcinoma, but you really have to think about a SPEN tumor. When you have calcifications also, you'll always think about neuroendocrine tumors, though in most cases, neuroendocrine are going to be more vascular. Just a really nice example, some duct dilatation, cystic lesion with calcification. You got to be going in the category of a SPEN tumor. And here's just a few more views, which shows some mild duct dilatation distally with atrophy of the very much tail of the pancreas. And here it is, that same case using cinematic rendering, which shows it very nicely. Now, when we talk about neuroendocrine tumors, right, just to mention them, sometimes neuroendocrine and adenocarcinoma look similar. Not every neuroendocrine is going to be hypervascular. When they're hypervascular, it's kind of easy. When we talk about neuroendocrine tumors, just to mention about some of the pitfalls, occasionally aneurysms or pseudoaneurysms can simulate a mass. We talk about metastases, looking like a neuroendocrine, particularly from clear cell renal cell carcinoma, but typically you've had a nephrectomy, and usually it occurs about a decade after initial treatment. And also with Mets, they're often multiple. We mentioned acinar cell before. We mentioned splenules as a potential pitfall by the tail of the pancreas. We talk about GIST or serous cystadenomas. So there are a number of things which can be tricky. Now, I'll mention metastasis again. We don't see them that frequently. The number one source is going to be renal cell carcinoma. Then things like lung and breast are things we'll mention. Here's a renal cell metastasis to the head of the pancreas. You can see as you get more images, there are multiple metastases. In the second case, renal can be solitary or multiple. But again, typically you've had a nephrectomy or at least a partial nephrectomy, as metastases typically occur a decade after the initial presentation. Here's a case of what looks like a mass in the pancreas, but then you look carefully, it's probably duodenum or in the groove between duodenum and pancreas, but surely the duodenum's involved, and this was metastatic melanoma. We've seen a number of large masses from melanoma. It can occur in the nodal chain, or it can be directly to the duodenum. But you can see on quick look, it looks like a pancreatic cancer. So you need to be very careful in this regard as well. Intrapancreatic splenule, the second most common location for accessory spleens by the tail of the pancreas. Again, the confusion potentially with neuroendocrine tumors. The thing about splenules, they enhance identical on all phases to the spleen. Neuroendocrine tumors are typically more vascular. Some rules: they should never be greater than 3 centimeters medial from the pancreatic tail. Again, the identical enhancement on all phases. And if you get desperate, a technetium scan can be helpful, but I think we typically do not have any problem. Here's a nice example, 2 cases of accessory spleens mimicking pancreatic neuroendocrine tumors. But again, the enhancement matches the spleen perfectly in both of these cases. Now, GIST tumors, we mentioned tumors of the duodenum before, like a duodenal adenocarcinoma or a MET from melanoma. But GISTs and carcinoids commonly occur and are vascular in the region of the duodenum. It can be very tricky. Gysts tend to be exophytic, and carcinoids tend to be endoluminal, so that can be somewhat helpful. But when you see a mass like this and you think it's pancreas, but you don't see dilated common duct and pancreatic duct, you know it's not going to be pancreatic adenocarcinoma. So you have to think, what could this be? Could this be duodenum? That's a good thought. Could this be nodes? That's a possibility. When you look at the lesion in all positions and all phases, you see that the portal vein and SMV are displaced. The lesion is large, but it's hypovascular. It's not invading. You can see the vessels are a bit stretched, but there's no invasion. And this is just a nice example of a GIST tumor of the duodenum simulating a pancreatic cancer. And this patient was referred to us to a multidisciplinary conference for pancreatic cancer. Obviously, this was not the case. Now, the prior study, the GIST tumor was not very vascular. GIST tumors, particularly when they're smaller, are very vascular. Here's a beautiful example of a duodenal GIST tumor. But again, you look at it, is this coming off the pancreas? If it is, then you say, well, maybe it's a neuroendocrine tumor. If it's coming off the duodenum, maybe it's a carcinoid tumor. So it can be tricky. I think the one thing you could say in this case, it's not going to be a pancreatic adenocarcinoma. Here's the lesion again on the coronal view. Again, it could be pancreas. It still could be a neuroendocrine tumor. Very nicely, the MIP imaging showing you the vascularity of the lesion as well as its orientation. And here's a couple other examples of peripancreatic GIST tumors. So again, in that area, they can be small, they can be larger, they can be very tricky. The bottom left, I would have thought about a neuroendocrine tumor. That's a good possibility. Again, could this be a carcinoid? Could this be metastasis? So again, there's a lot of overlap. At times, the diagnosis is going to be made by biopsy, but I think as radiologists, we need to try to really think about the possibilities and again, make sure the patient is managed correctly. I mentioned about solid serous cystadenomas, which make up less than 5% of lesions. They look like neuroendocrine tumors. You're not going to confuse them typically with adenocarcinoma. They can have calcifications. They're solid. They're vascular. They're large. Look identical to neuroendocrine tumors. They're benign, but they're typically going to be resected. It's kind of a really good pitfall. We talk about unusual tumors that are near the pancreas, paragangliomas. Paragangliomas are basically extraadrenal neuroendocrine tumors. They can look like neuroendocrine tumors. Again, they could look just like a pheochromocytoma. We talk about that. But a really nice example, 3 different cases of peripancreatic paragangliomas. So we've now looked at a number of things. Pancreatic cancer is a difficult diagnosis when it's small. When it's larger, the diagnosis is easier, but there are a number of pitfalls. Some are benign etiologies. Groove pancreatitis is one good example, right? We don't want to be calling that cancer. We talk about annular pancreas. We then talk about splenules, all things that can mimic pancreatic cancer perhaps, but are benign and are not cancer. We talk about other tumors ranging from neuroendocrine tumors. We talk about lymphoma. We talk about tumors that arise not from the pancreas, but from the duodenum, be they GIST or carcinoids that can look very similar. So again, knowing all of these possibilities is important. Understanding the potential mimics is important and will allow you to do a better job for your patients and your referring clinicians. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.